Good morning, everyone. My name is Karim Bensalah, and I'm very honored to be invited to this meeting, and I'm happy to share with you my talk on the limits of partial nephrectomy. I'm sorry I couldn't be there, and I hope next time I can make it. So the goals of partial nephrectomy are well known. I'm sure you're all aware of that. The first one is to ensure long-term oncological control while preserving renal function and trying to minimize morbidity. We know from many publications and from this meta-analysis that partial nephrectomy is not inferior to radical nephrectomy. And it's very clear now that partial nephrectomy can better preserve renal function compared to radical nephrectomy. It's optimal to prevent the decline in eGFR and the onset of a new CKD. And as such, the EAU and most of the national societies recommend to offer partial nephrectomy to patients with localized T1 tumors. And now, you know that the robot has spread all over the world, and in many countries now, the robotic approach is the preferred approach. And we've been using the robot now for a long time. The results seem to be optimal. And we have an abundant literature describing the result of robotic partial nephrectomy and that compared it to those of open or laparoscopic partial nephrectomy. And we know that robotic partial nephrectomy is associated to a decreased morbidity. As you can see in this table, there is less bleeding, less transfusion, less complication, length of stay is greatly diminished, and there seems to be better results regarding mortality or recurrence. This is some data from our institution where you can see the evolution of the outcomes of partial nephrectomy over the years. And as you can see, we got our first robots in 2010 and our second robot in 2017. And this is the length of stay that went from 7 days to 1.7 days. And nowadays, the majority of patients live on day 1. So the robot really has allowed us to obtain optimal outcomes. And robotic partial nephrectomy can be done in extreme situations, such as the one in obese patient, for example. This is a recent publication of a multicentric French study of 166 patients who underwent robotic partial nephrectomy. And you can see that the overall complication rates and major complication rates, as well as length of stays, were comparable to that of normal fit patients. Solitary kidney is another extreme situation. This is again another publication from the French group comparing open partial nephrectomy versus robotic partial nephrectomy. And you can see that both techniques are at least comparable with probably benefits of the robotic approach with 40% of the case of trifecta achievement versus 34% in the open partial group. Robotic partial nephrectomy is also feasible for large tumors, such as this one. This is a patient in whom I did a robotic partial nephrectomy, one who had a big tumor. And the table on the right summarizes a recent publication, multicentric European publications of patients with T2 tumors who underwent robotic partial. And you can see that the outcomes regarding warm ischemia time, blood loss, and complications are really optimal and comparable to that of patients with smaller tumors. This is the experience from Rennes, my institution, where we did a lot of robotic partial nephrectomy for these complex tumors. And this is the case of a patient of mine, a young girl, who had a really big tumor, as you could see on the CT scan. And I'm not going to show you the entire videos, but some of it. And as you can see, the robot allows you to do a very nice dissection and a nice enucleation, even for these very large tumors that are very challenging. So, in the first part of this talk, I showed you that robotic partial nephrectomy is a very nice technique with very few technical limits. However, we know that there are more complications associated with partial nephrectomy. This is some data from the previous meta-analysis that I talked to you about. The risk of bleeding is increased. The risk of fistula is increased. Even though there is limited impact on quality of life, there is a higher morbidity than with radical nephrectomy. And we only have one randomized trials. You know one. You probably know this trial that was published in 2011. Also, it has many limits. It's a trial done in another era with small tumors, many patients in many centers over a 10-year period. Well, this trial, the only one that we have, showed that there was no difference in terms of overall survival between partial nephrectomy and radical nephrectomy. With partial nephrectomy, there's an increased risk of positive surgical margin that can lead to more recurrences. This is a publication that goes back to 2011, a large series of partial nephrectomy with positive surgical margin. And you can see that the recurrence rate is increased in case of positive surgical margin. And although there does not seem to be any impact on survival, it might not be true for complex and high-risk tumors, the ones that we tend to operate more and more. Then, when you look at the impact of renal function and the risk of mortality, this is a very important publication that was published 20 years ago in the New England Journal of Medicine on a large series of patients with chronic renal insufficiency. And you can see that the risk of death constantly increases with the decline of eGFR. And that was based on that many of us made the hypothesis that partial nephrectomy could lead to a better survival compared to radical nephrectomy. However, the medical renal insufficiency is different from from the one you have that arises because of surgery. This is some data from the Cleveland Clinic. You can see that the brown curve is related to medical CKD, whereas the yellow curve is related to surgical CKD. And in both cases, you can see that surgical CKD is associated to similar survival as patients who do not have chronic renal insufficiency. So the loss of nephron, that does not seem to be that important on a population scale. And this is a very interesting review, a Cochrane review, that was published in 2018. They analyzed almost 140 studies, and out of these 137 were excluded because they were deemed to be of poor quality. And the only one study that was included in qualitative synthesis was the one referring to the randomized trial that I showed you. And when you look at cardiovascular events, hypertension, permanent hemodialysis, or development of chronic kidney disease, the conclusion of this meta-analysis is that, of this systematic review, is that the authors did not find any evidence for this outcome to be more prevalent in patients receiving radical nephrectomy compared to partial nephrectomy. This is another very interesting publication from the Mayo Clinic on their very large population of patients who underwent partial or radical nephrectomy for T1 masses. And they found that radical nephrectomy was associated to an increased risk of CKD and 3 times risk of EGFR less than 45 millimeter per minute. However, there was no difference in all-cause mortality. It means that many patients who see their renal function decreasing will not die sooner from that event. So, in the end, the question is the following. Is the morbidity of partial nephrectomy worth it? Because, as I showed you, we know that partial nephrectomy will provide the same cancer control despite an increased risk of positive surgical margin, and it will better preserve renal function. And this has to be put into balance with a slightly increased risk of morbidity. And as you all know, and as you all do in your daily practice, the decision to perform a partial nephrectomy versus radical nephrectomy or thermal ablation relies on many parameters: renal function, tumor complexity, the presence of toxic perirenal fat, the age, the comorbidities, your expertise, whether it's the surgeon's expertise or the center expertise. And this is based on that you will be able to better evaluate the risk of the patients and decide if it's worth it to do a partial nephrectomy. And there are some predictive tools that you can use to help you decide. The one on the left is the one that we published in France. This is a multicentric evaluation, and we found that major complications were mostly related to 5 factors: the renal score, the ECOG factor, the comorbidity score, gender, and hospital volume. And this predictive tool is one developed by an American team. And as you can see, there are other factors that are quite similar to ours: the age, presence of diabetes, preoperative EGFR, proteinuria, tumor size, time for surgery, or solitary kidney. And these are not perfect tools, but they can help you decide whether or not you should do a partial nephrectomy. So as a conclusion, I would say that partial nephrectomy remains the primary option to treat localized renal tumors. There are very few technical limits when the team is experienced. You can do that in extreme situations, but the benefits of partial nephrectomy have to be balanced with an increased morbidity, and it is not always sure that the renal preservation will actually benefit the patient over a lifetime span, and the indication has to be taken by with taking into account many parameters related to the tumor, the patient, and the institution. Thank you very much again for the invitation, and I will be happy to discuss and to take any question with you. Thank you.